Great. Okay. I just want to welcome everybody to Policing and Mental Health on the Front Lines. I want to thank you all for joining us today. We really appreciate it. We know it's a busy time of the semester. We'll be sharing a student project today, and we have spent the entire year working on this project. The students are going to explain in detail, so I'm just going to introduce this just a wee bit as a student-centered, publicly engaged research project that's in collaboration with community organizations in Waterloo, Iowa. And the students have driven all phases of this research from question selection and development through data collection and analysis. It's just been great. Could you advance the slide for us, Khan? But before we start, I want to thank the Iowa Initiative for Sustainable Communities, directed by Travis Krause, and Public Policy Center. Both of those provided us with support so that this project was possible. Travis Krause has been absolutely key in helping establish this project. This project is one of many that he facilitated in Waterloo this year. And so before we start talking about our project, I thought it would be nice to have Travis explain a little bit about how this collaboration with Iowa communities works and what this is sort of a little piece of that he's got going on this year in Waterloo. Travis?
Yeah, well, first of all, thank you very much for the opportunity to say a few things about IISC, which is the acronym for Iowa Initiative for Sustainable Communities. I'm going to keep it brief too, just because I'm very eager to get to the presentation as well. But the Iowa Initiative for Sustainable Communities is an engaged learning program housed in the School of Planning and Public Affairs. And if you've not heard of either of those things, that's okay. It's hard to be noticed when there's so many things happening on campus, right? But we have, the Iowa Initiative for Sustainable Communities has been around for 11 years. And the School of Planning and Public Affairs is actually a brand new name. So if you haven't heard of that, it's because it was called the School of Urban Regional Planning up until this year. This is our first year having a new master's degree program. It is a Master of Public Affairs. So hence the name change for our school as well. So while we're housed in the School of Planning and Public Affairs, we actually work with departments all over campus. We've been around for 11 years and we work with, we partner the University of Iowa and students and faculty and staff with communities across the state. And one of the kind of special things about IISC is that we form partnerships with one or two communities each year that get a lot of attention and resources and time and energy from students and faculty. And this year, Waterloo happens to be one of our IISC partners. The other is Manchester, Iowa. So that means we've done, I think we're like 18 projects in Waterloo this year, so quite a bit. And it's actually been a really great partnership for us. We've been around long enough that I think the students that we work with do such quality work that we're fortunate that communities now reach out to us instead of us trying to go find them. So that's what happened with Waterloo. They reached out to us inquiring about how to become a partner for the University of Iowa, and it all worked out really well. I'm also just super excited. We have kind of veterans of IISC, the departments and faculty members that kind of work with us each year. So this is the first time that IISC is partnered with criminology, and hopefully not the last, because it's just been really great. And I see that there are lots of ways that like the students and teams from this particular discipline can do a lot of good work in Iowa and the Iowa Initiative for Sustainable Communities. So I just appreciate that so much, and Dr. Heimer's leadership and patience as we worked through like the unpredictability of community engagement, and I think the students know what I'm talking about as well. So it's along with that unpredictability, hopefully like you also have a sense of like accomplishment, because what you're doing is going to really be impacting real people's lives. So I really appreciate that. Waterloo is excited about all of the projects that are happening this year, and they've proven to be a community that is ready to take recommendations and move them forward. So I expect that for this project as well. So, and the other thing I just want to say, I give a shout out to Xandra and Antonio. I hopefully it was a pleasant surprise for you guys to be able to do a second project with IISC. So thanks to you too.
Thanks, Travis. So now it's my pleasure to introduce the team to you. And I just want to introduce them kind of globally, and then I'll just introduce them each by name. First of all, this is a fabulous team. We have been working together all year. And as Travis said, we had sort of our ups and downs, like in any research project. We had times where we weren't sure if anything was going to happen. And then things really came together because of the great work of this fabulous group. It really is a dream team. I recruited, after Travis and I talked this summer about some possibilities, I recruited all of these folks from my past courses. And I have to say that this is probably the most fun and rewarding group I've ever had the pleasure to work with on a project. They're brilliant, they're motivated, they've worked so well together, amazingly well. And they're all graduating. So this is kind of like a capstone celebration kind of thing, except for Cecilia, who's going to stay and work with me another semester. So congratulations to all of you as well. I always tell this group that they each have a superpower. I recruited them all because they each have this really special superpower. And that is so true, whether it be just this like natural talent for interviewing people or data analysis and data management, organizing this group. They organized themselves largely, which is like a feat. That was beyond me. Writing, developing Qualtrics surveys. They all have so many talents. It's just been really amazing. And you're going to see all that today. Some also, they come from diverse majors. They all have some connection with criminology, but as you'll see when I introduce them, they come from a bunch of different majors. So first team member, I'll just go in order, is Anjali Puranam. And Anjali is a human physiology major and a criminology minor. Aurora Palmias, who is a bio major in the genetics and biotech track with a minor in criminology. Cecilia Bonilla, who is a criminology major and is going to stick around with me for a little longer. Maya Rhodes, who is a sociology and ethics and public policy double major and has a social science analytics certificate that she's earned. Caitlin Absher, who is a criminology major. Khan Spanudakis, who was a criminology and sociology major. She actually graduated in December and liked us so much, she decided to stick around with us. Antonio Woodard, who was an undergrad criminology major, who was in class with me some years back, and a theater minor, and is now completing and graduating with his master's degree in social work. Alexandra Scores, who is a journalism and political science double major with a minor in criminology. Omar Lopez, who is a criminology major, and Natalie Gradnitsky, who is a criminology major and has minors in sociology and rhetoric. And so I'm going to turn it over. I'm not going to speak anymore now. I'm going to turn it over to the team. But I do want to mention, if you have questions, if you just write into the chat, have a question. At the end, I will call on people kind of sequentially from the chat to ask their question, and the team will answer the question if that works for folks. We've been doing that in our department and it seems to work pretty well. So without further ado, team, take it away.
All right, thank you to Karen for that wonderful intro. To begin, as our team started our research, we realized that there was an increasing number of mentally ill people in the criminal justice system. Studies estimate that around 6 to 10% of all police contacts with the public in the US involve people with serious mental illnesses. So police are usually the first to respond to someone in a mental health and/or substance abuse crisis. They have become frontline professionals who manage people when they're in crisis. Although they may be the first to interact, police officers might not have the appropriate tools or training to handle crisis intervention. Police are criticized sometimes for using unnecessary force when encountered with people with mental illness. People with untreated mental illness are 16 times more likely to be killed during a police encounter than other civilians approached or stopped by law enforcement. The police's obligation to serve and protect extends to people experiencing a mental health episode. A major goal is to better prepare and train police to handle these situations, so they can divert people experiencing a crisis to community mental health resources, where they can there get the help that they need. The police often fulfill the role of gatekeeper in deciding whether a person with mental illness should enter the mental health care system or the criminal justice system. As a research team, this topic of police and mental illness really sparked our interest. We talked to the mental health resources in the Waterloo community, including Black Hawk Grundy, Pathways, and Elevate, to name a few, to gather some more information about the mental health resources available to the community. We then decided to delve further into the Waterloo Police Department and their interactions with people dealing with mental health. Next slide.
Crisis intervention training. Crisis intervention training is a specialized policing curriculum intended to reduce the risk of serious injuries and arrests during police interactions with individuals experiencing mental health crises. The training is primarily focused on the initial stages of officer interactions with the goals of de-escalation, as well as navigating individuals to proper treatment needed within services offered by local mental health providers as an alternative to arrests. Throughout the course, police officers learn about the various types of mental illnesses and how these impact individuals differently. Additionally, officers are taught how to identify individuals with mental illness or who may be experiencing an episode of mental illness and apply catered approaches to ensure that goals can be met. Pertaining to the history of CIT, the training was first developed in 1988 within the Memphis Police Department after an officer of MPD had used lethal force on Joseph Robinson, who was a 27-year-old man in the midst of a mental health crisis. Soon after, police departments nationwide began to implement programs similar to CIT for the purposes of preventing tragedies like Mr. Robinson's from occurring. According to the National Alliance on Mental Illness, research conducted on CIT has shown it to be an effective training, resulting in numerous benefits for officers, individuals with mental illnesses, and the community. First, relating to officers, CIT promotes safety, considering it reduces officer injuries by up to 80% during mental health calls. Along with that, CIT improves officers' attitudes and knowledge regarding mental illness. Moreover, CIT allows for officers to have greater time efficiency since it decreases the time officers spend when responding to mental health calls. Furthermore, in reference to individuals with mental illnesses, CIT reduces the possibility that they are arrested or injured during officer interactions while increasing the likelihood that they receive mental health treatment. Lastly, CIT has proven to be a cost-effective for the community, being that individuals with mental illness are diverted to community-based treatment, which is considerably less expensive than incarceration. Next slide.
As a team, we acknowledge that the quality of interactions between citizens and police depends on the individuals involved and their characteristics. Because of this, we wanted to look at the demographics of Waterloo. In Waterloo, the population is about 67,000 people. According to the latest census, about 10% of people reported having a disability, 7.6% reported not having any insurance, and 17.4% reported being in poverty. As far as the racial makeup of Waterloo, about 70% of people are white, 17% are Black, and about 7% are Latinx. 49% of the population of Waterloo are women. In comparison to Cedar Rapids, which has a population of 133,000, about 81% of Cedar Rapids' population is white, 7.8% is Black, and 4% is Latinx. And if we compare this to national populations, within the US, about 61% of people are white, 13% are Black, and 18.5% are Latinx. Next slide.
Elevate is a behavioral health center in Waterloo, Iowa, that was founded by Bob Lincoln in November 2020. They provide mental health therapy, medication management, psychiatric evaluation, and clinician follow-up. Elevate recently received a grant from the Substance Abuse and Mental Health Services Administration, which allows them to offer services to those without insurance. They also have a mobile crisis response team, which is a 24-hour service that anyone can call if they are experiencing a mental health crisis. As of April 1st, the mobile crisis team serves 12 counties. In addition to the mobile crisis team, Elevate began a partnership with the Waterloo Police Department in February of this year. Now, there are mental health professionals that act as law enforcement liaisons. They ride along with police officers to mental health calls. The aim of this partnership, according to Waterloo Police Chief Joel Fitzgerald, is to decriminalize behavioral crises and reduce stigmas by having crisis specialists available, both within the police department and through Elevate and other service providers. Next slide.
So to start off our study, we decided to interview several people within the Waterloo area in order to narrow down our focus and just sort of give us the direction which the study was going to go. The first thing that we noticed was that there seems to be a relatively high number of resources in the Waterloo community. So we wanted to sit down with those community leaders and mental health professionals to sort of get the lay of the land in Waterloo. We first spoke to Mary McKinnell, who is the Director of County Social Services, who told us about the great resources in the area, such as Pathways and the Mobile Response Team. But one concern that she highlighted was that there was sort of a lack of communication between these coalitions, who all have the same goal of helping people with mental health issues, but lack the communication in order to best do that. This theme of poor communication was something that we sort of continued to come across. We then spoke with Chris Latta, Director of Behavioral Health and Emergency Care at Mercy One, who told us that Black Hawk County really does see a host of different mental health issues. You name it, we've seen it, he said. He also told us that while his clinics and the Waterloo PD have a great relationship, meeting quarterly, there are still a high number of individuals suffering from mental health crises that end up in jail due to a lack of long-term services in the area. If they can't be in the hospital or the street, then the police feel that they really have one option, taking them to jail. We also spoke to Tom Eckes, the Director of Black Hawk Grundy Mental Health Services, who reported that 30 to 40% of referrals who come to them are from corrections, either coming in or out of the criminal justice system. We then learned of the new program in the area, Elevate, which we just talked about, run by former Director of County Social Services, Bob Lincoln, who informed us that the new chief in Waterloo is really attempting to reform local law enforcement and is making a push for community policing. Bob wrote the grant proposal that's funding Elevate program and their connection with the Waterloo PD. We also think it's important to note that that Waterloo recently hired the new chief of police, Dr. Joel Fitzgerald, who is not only a 20-year veteran, including serving as chief of police for Fort Worth, Texas. He also has a doctorate in business administration. This new chief has come in dedicated and open to reform when it comes to best serving his community members suffering from mental health crises, and just general reform when it comes to mental health in the police. An idea that had yet to be truly emphasized in the same way during these officers' time on the Waterloo PD. Also, Sheriff Tony Thompson met with us often through our process and helped guide our direction as a major supporter of reform in law enforcement with regard to addressing mental health crises. We felt that it's important to understand the Waterloo PD's view on mental health issues in general, mental health training that they go through, and the way that they respond to mental health calls. Because at the end of the day, they're the people responding to the calls. They're the ones on the front lines. So we were able to develop a rapport with Major Leibel, who gave us a rundown of the department's protocol and resources available for officers when responding to a mental health call, such as a community resource Excel sheet readily available in all squad cars. However, we also wanted to gauge the feelings of patrol officers in the department, and in order to do that, we designed a survey, which Aurora can help explain a little more.
So like Natalie mentioned, we were really interested in understanding the Waterloo Police Department's experience and relationship with mental health in the community. In order to do that, we designed a Qualtrics survey. We opened this survey up for 2 weeks starting March 15th, and it was distributed to the department through email by Major Leibold. The questions in our survey centered around a few major themes, which are shown in the slide. The first theme was perceptions of mental health. We wanted to see how comfortable officers were with discussing, handling, or advocating for mental health. For example, we asked officers how prepared they felt when responding to a mental health-related crisis. The next theme of questions centered around community services, namely how officers perceived the community services that were available and how familiar they were with communicating those resources to the community members. For example, we asked how they perceived the relationship between community mental health resources and their department. Our last theme was to include a variety of demographic questions, such as rank, education, and race or ethnicity. Because we were interested in how officers felt about CIT training, we first asked them if they were CIT trained. If they said yes, we asked for how long they were trained, and if they said no, we asked whether they would be interested in receiving training. One important thing to note is that because our survey was not completed by the entire department, we can't say that these responses are necessarily representative of the department as a whole. For example, we noticed that few people began the survey overnight compared to those in the morning and afternoons, meaning it's possible that officers from some shifts were represented more highly than those from other shifts. Next slide. These are some of the demographics that we were able to obtain from our study. Again, these are only representative of those who took the survey. We did reach out to the department for some more accurate estimates of their demographics, but we haven't heard back yet. According to our survey, 78% of respondents were male. For race and ethnicity, 95% of respondents were white, with another 2.5% being Hispanic or Latino, and the remaining 2.5% indicating being mixed or multiracial. For education, 85% of our respondents had an education beyond high school or a GED. In terms of time on the force, 83% of officers had been with the department for over 10 years. And when it came to work-related stress, 56.1% of officers reported high to extreme levels of stress, while 41.4% reported at least some stress or moderate stress, and only 2.4% reported no work-related stress. Again, while we don't have the demographics of the department as a whole, it was important for us to keep these demographics in mind when it came to evaluating the implications of our quantitative and qualitative data. Next slide.
We asked officers the extent to which that they believe responding to mental health calls is the role of a police officer. While it's encouraging that the majority of respondents said that it was a very important role, there's still a quarter of them who don't believe that responding to these calls is the role of a police officer. We just wanted to point this out because at the moment, community members are still calling 911 in these situations and will continue to do so until the community is able to reach out to other resources. Next slide.
So in this question, we really wanted to know how much officers knew about this new partnership with Elevate. We know from our talks with individuals that the Elevate partnership had somewhat of a rocky start. Elevate personnel would show up at the scene and officers didn't know who they were and what their role was. At the time that the survey was sent out, the Elevate partnership was still fairly new. But as we can see from the result, the majority of officers had at least some moderate knowledge about the Elevate partnership. 23% were extremely knowledgeable about the partnership, and 16% had some knowledge, with 11% not knowing about this partnership at all. In this question, we asked officers about the program referral guide that they have in their cars. This has a list of all the services in their community. It has a list of names, addresses, phone numbers, and specialty services in Waterloo. This referral guide was heavily noted by many that we interviewed, and so we thought it would be an important thing to ask these officers. In the original survey, I need to note that some responses noted that they had never responded to a mental health call. So the following percentages that you see are adjusted and based on the responses of individuals that had encountered a mental health call. As you can see, 46% of those officers had never used the referral guide, 26% did not use it often, only 10% using it in some cases, and 16% using it in most cases.
Officers were then asked, how do you perceive the relationship between the community mental health organizations and the department? In the survey, 9% of officers responded that they had an excellent relationship, and around 32% of respondents said that the department had a very good relationship with the mental health services in the community. As you can see, a majority of officers said they had an excellent to fair relationship between the organizations and their department. This is interesting because of the lack of officers who referred to their Excel sheet. There seems to be a disconnect. If officers perceive that they have a good relationship, it would seem that they would be reaching out and contacting these community resources for help. This can be a source of improvement by increasing the strength of these relationships to increase the amount of people being directed to these community mental health services and kept out of the criminal justice system. In the survey, 30% of the officers responded that they were CIT trained, and 70% said that they were not CIT trained. This is a relatively small percentage of officers. Ideally, the whole force will be trained in CIT because they are all responding to calls that could potentially involve someone experiencing a mental health crisis. Of the officers that responded that they were not CIT trained, around 68% responded that they would not like to be CIT trained. Through our interviews with the officers, we found additional evidence that officers were reluctant to additional training. This evidence strengthens our interpretation that a cultural shift in policing towards CIT training and mental health awareness is needed for the training to be more widely effective. The officers will be more keen to use what they learned during CIT if they desire the training and see the positive impacts. Officers that take CIT and aren't interested in retaining the information will be less effective in implementing the training into their interactions. Next.
In our survey, we included this scenario question from one of the crisis intervention training manuals used in the state of Wisconsin. The scenarios found in these manuals are used as practice questions and teaching tools during actual training sessions. We modified the scenario question, removing certain words such as previous occupations and medical terminology that could have primed the officers' responses. The officers were required to spontaneously generate their own course of action for this question. Next slide.
Of the 54 officers who took the survey, 36 responded to the scenario question. That is a 30% response rate when looking at the entire police department. Next slide. Of the 36 officers who responded to the scenario question, 11 officers were trained in crisis intervention. Next slide.
We coded the officers' responses based on a variety of categories. Then we coded the response from Elevate's mental health specialist to the same scenario question to use as a comparison. This comparison is important because this individual works as one of the law enforcement liaisons embedded in the Waterloo Police Department. We included the responses from the specialist at the bottom of the following slides. Of all the categories, we found that these 5 had the most relevant and interesting findings. Next slide.
During our research, we found that crisis intervention training may have an effect on what officers check for when arriving at a scene. In response to the scenario question, 46% of CIT officers mentioned that they would check for physical and/or mental well-being of the individual at the scene, whereas only 28% of non-CIT officers mentioned that they would complete a similar check. When the Elevate mental health specialist answered, they made it a point to mention checking physical and mental well-being as separate steps. From this data, those who had crisis intervention training were more attentive to the well-being of the individual than those who did not receive the training, making them more competent in assessing the scene and determining next steps.
In response to our scenario question, which was pulled from an official manual, 9% of CIT officers would call a supervisor for assistance while at the scene, whereas 20% of non-CIT officers mentioned a similar step. This could be attributed to CIT officers feeling more prepared and equipped to handle a scene without assistance. The Elevate mental health specialist embedded with the police department did not mention calling any supervisors because they're trained to handle situations like this on their own. In general, when you feel like you can handle a situation, you're less likely to ask for help. And this slide shows that crisis intervention training makes officers feel more confident while at a scene. Next slide.
This category consists of officers who mentioned calling other social services to the scene to aid in de-escalation. In this category, we decided to look at the frequencies rather than the percentages. 3 CIT officers mentioned that they would call another mental health provider to the scene, while 5 non-CIT officers mentioned a similar step. There was no data from the Elevate mental health specialist in this category because they are considered outside mental health providers. This reinforces the idea that was mentioned in the previous slide. Those who receive crisis intervention training feel more proficient in handling a mental health call than those without this training. Next slide.
In response to our scenario question, 9% of CIT officers mentioned that they would take the individual to a hospital or they would call an ambulance to the scene, whereas 20% of non-CIT officers mentioned similar steps. The Elevate mental health professional did not mention taking the individual to the hospital, but after talking a little more, we realized that it may be protocol to take someone to the hospital when they are deemed suicidal. CIT officers should be more aware of community services and would be able to divert suicidal cases to services that provide continued treatment rather than the crisis management of an emergency room. Also, CIT officers should be more knowledgeable in determining whether an individual is suicidal. There is a higher possibility of non-CIT officers misdiagnosing someone as suicidal because of their lack of training. Next slide.
In response to the scenario question, 18% of CIT officers mentioned that they would not intervene in this situation because they did not consider it a police issue, whereas 4% of non-CIT officers mentioned something similar. Keep in mind, this scenario question was pulled from an official training manual. However, after speaking with some officers, we realized that there is a divide in the department in terms of crisis intervention training. Some officers feel forced to attend these sessions and might not pay attention or retain the information presented. Next slide.
As part of our research, I was given the opportunity to observe CIT training taught to the Waterloo Police Department on April 19th. The course was taught by a former police officer who had great experience in the field of policing and now holds a job teaching CIT to officers. There were 4 principles emphasized throughout the training deemed essential to CIT practices. The first principle talked about was cultural consideration. Cultural consideration is defined as understanding the cultures of various groups of people, which may influence their behaviors or perceptions during cross-cultural police interactions. The word culture and cultural consideration entails, but is not limited to, an individual's values, norms, and traditions. In reference to cultural consideration, the instructor told officers that for their CIT techniques to be effective, they must, quote, understand the way members of different cultures view the nature, cause, and treatment of crisis intervention behavior by police, end quote. When analyzing the current demographics of the Waterloo Police Department, the strong homogeneity of white elderly men may function as a possible barrier for allowing officers to be exposed to different cultures of racial, gender, and age groups while at work. In turn, this could prevent the department's grasp of cultural consideration with the diversity within the aggregate residents of Waterloo, therefore potentially deterring the effectiveness of CIT-related practices. The second principle mentioned was cultural intervention strategies. Cultural intervention strategies refers to dialogue and actions officers enact when engaging with members of the Waterloo community. Officers were taught ways of approaching individuals in a more positive manner to assist them with achieving goals associated with the CIT. The purposes of cultural intervention strategies were to alleviate any stress individuals experiencing mental illness may encounter during police interactions, and to change their perspective by letting them know officers were there to help as opposed to detain or arrest them. Examples of cultural intervention strategies discussed were that officers should speak and stand more passively when conversating with residents. The instructor emphasized the necessity of cultural intervention strategies by telling the officers that most of their trainings revolve around people with guns. However, most of the time, the officers are not in that particular situation, which is why techniques like cultural intervention strategies must be taught and embraced. The third principle talked about was the well-being of police officers. When speaking about this topic, the instructor stated that he had wished officers were assigned a therapist after completing their academy. He said that he knew the job was stressful and that stressed officers make bad decisions. He later followed this by saying, based on his experience, he knew that stressed officers would be less effective at carrying out CIT procedures due to the nature of their mental state. When looking at the quantitative data gathered, 91% of officers said they experienced moderate or higher levels of work-related stress. However, of that 91%, 55% said they experienced high to extreme levels of work-related stress. This indicates that some officers may be constrained from engaging in efficient CIT practices owed to their considerable levels of stress. Lastly, a fourth principle talked about was the role of police officers during mental health calls. Officers were told that when called to a mental health crisis, they must understand their role, which is not a problem solver. Rather, they are a mediator to mental health resources. Our qualitative data suggests that sizable numbers of officers contradicted this view, considering that over 20% of the officers said they would not intervene in the given hypothetical, which called for police mediation. The lack of cohesion in understanding their role as an officer in a mental health-related call cites a potential dilemma for officers called to these situations. Next slide.
Myself and two other students had the opportunity to interview police officers. Myself, Con, and Natalie each spent 4 hours with different officers during different shifts. This gave us the opportunity to ask questions and find out more information. I learned some more about the department's organization, the rankings of the officers, and how they interact with each other. I also asked questions about the community members and how those members interact with the Waterloo Police Department. I discovered that a significant portion of community members are not supportive of the Waterloo Police Department, and that there's a divide between the citizens and the law enforcement who serve them. I also learned that a big challenge in Waterloo, among other places, is substance abuse. According to the National Institute for Mental Health, about half of people with substance abuse issues also suffer from mental health issues and vice versa. Because of this, we know that mental health and substance abuse are deeply intertwined and both affect many individuals. I also learned that some officers believe that the community mental health needs to be addressed along with substance abuse, and that they believe that mental health will not be fully addressed until substance abuse also is. I also learned some more about how officers feel about Elevate and the social workers who work with them. As mentioned before, social workers from Elevate ride in patrol vehicles. This relationship didn't necessarily have the best implementation, and some officers did not believe that relationship would work well because of this lack of good implementation. Currently, officers believe that in theory, the relationship between Elevate and the Waterloo Police Department could work well, but currently Elevate employees are ending up at calls that are not ideal for them. When riding in a patrol car, Elevate employees go wherever the officer does. So if an officer responds to a non-mental health related call, the Elevate employee may end up at a robbery, a burglary, or some other crime scene instead of at a mental health call where they could be better used. Next slide.
Where Waterloo has a population of about 67,000 people, Cedar Rapids is about 132,000, so nearly double. A much larger city and a very different overall climate. Although there's a significant difference in the population sizes and the city environments, we found that it was important to compare the overall significance of Iowa cities and how they differ in their variety of responses. Cedar Rapids has taken a different approach to mental health response by having a designated mental health officer. This is different to the Waterloo Police Department in a couple ways. This single officer works to bridge the gap between social workers or other mental health professionals and police officers. Another part of the designated officer's job includes calling insurance programs, therapists, or psychologists, which can oftentimes happen daily. A three-year-old program over at Cedar Rapids, the officer currently serves about 525 logged persons experiencing mental health related calls. There's a group that the officer and the social workers deal with in Cedar Rapids on a weekly basis. There are only a small number of officers in the Cedar Rapids PD that are CIT trained, similar to that of Waterloo, where not everyone is trained. A similarity between the two cities is the reluctance of officers wanting to be trained, as the Cedar Rapids mental health officer explained. And despite not everyone being CIT trained, the department has found this program to work well with the hospitals and the other mental health resources when they are in need. However, while it does work well, the mental health officer does hope that the program will expand to more than just one person bridging that gap. Next slide.
So building off of the previous slide, I like to delve into mental health interactions at the Iowa City Police Department from a different lens. So I'm one of the, for my practicum within my program, I'm one of the victim service coordinators at the Iowa City Police Department. It's a relatively new position. This is going on year 2. And my predecessor, Ann Thompson, she was the first person in the position 2 years ago after one of our sergeants wrote a grant for the position. And she's actually a full-time employee there now. And essentially our role is to, like Alexander explained, in the Cedar Rapids Police Department, there's a social worker, mental health crisis individual that deals with the initial point of the crisis, whereas we deal with the like the aftermath post incident, dealing with like all types of crimes, general crimes, but like particularly with mental health. We deal with individuals during, like I said, the aftermath of an actual crisis, where the follow-up is just as important. As we all know, officers don't always have the capacity to follow up and make connections and connect individuals to resources. So that's where we kind of come into play to reach out to those individuals and make sure that they're getting connected to whatever it is that they need, whether it be doing welfare checks, short-term crisis counseling, referring individuals to services, and just figuring out what it is that they need. Pre-COVID, this would look like us going to individuals' homes, escorted with an officer to check in, like I said, and do a welfare check to see how they're doing. But now with COVID and everything is over the phone. And if a situation or crisis is serious enough, we will likely go to their homes, but like that doesn't happen often. So just to name a few of the resources here in town in Iowa City is the mobile crisis outreach. So individuals that are experiencing suicidal ideations, is unsure of psychiatric hospitalization is necessary, crisis de-escalation or referral to community resources. So during the initial visit, the counselors will ask questions and do some assessments about the situation, asking questions about their mental health history, developing a safety plan. And if counselors feel there's imminent harm to self or others, then first responders may be contacted. And then post visit, a follow-up call the next day from the counselor will be directed to the individual regarding further counseling or referrals, and visits may be advised. And then we have the community crisis line here in Iowa City, which is just another additional resource. And within the community crisis line, there's like a coping with suicide loss support group. For those of you that don't know, secondary victims to suicide, there's a high chance of those secondary victims also having suicidal ideations if a loved one has committed suicide. So that's a resource that I refer a lot of people to. And then here we have the GuideLink Center, which is relatively new as well. I believe it opened about a month and a half ago, 2 months ago. I had the pleasure of touring the facility there. And it's essentially an on-site assessment and stabilization outside of a hospital setting for those over the age of 18 years old, supporting those experiencing mental health or substance use crisis, instead of sending individuals to the ER or calling the police and relying on incarceration. And if law enforcement officers engage with someone in crisis, they just take them there, and this just lessens the burden of emergency personnel. And not just law enforcement officers, but family members can also take individuals there instead of calling 911 or sending them to the emergency room. And regarding the Iowa City Police Department, their CIT training is during the academy, which is a problem, and it's not frequent enough to sharpen their skills, as some of them have been working there for decades and so on. So I feel like again, the CIT training isn't frequent enough. Like, they need to have that continued exposure of getting the correct training and things that they need to, like I said, sharpen their skills. And with that being said, the expectations are not for officers to be completely knowledgeable of the DSM-5, which is the Diagnostic Statistical Manual of Mental Disorders. However, their reactions and responses to these incidents dictate how individuals are positively or even negatively impacted by their discretion and authority. Next slide.
The biggest takeaways from the surveys, the ride-alongs, and the interviews over the last year can be summarized in these 3 main points that you see. So the importance of CIT, the direct and open lines of communication, and also the Elevate partnership. For the importance of the CIT training, from the data from our survey, we know the percentage of CIT trained officers in the department is around 30%. But when asked, 67% of individuals that were not trained said that they did not want to be CIT trained. I will also say that at the time of the ride-alongs and at the time that we were analyzing the survey responses, the police were being trained, so there is possibly more trained officers in the department now. But the percentage of individuals not wanting to be trained still remains high. We need to emphasize that CIT is not just for the individuals encountering this mental health crisis, but it is also for the police themselves. The training provides safety for the officers and the individuals. We also know that there's a difference in the way CIT trained officers respond to calls and the way non-CIT officers respond to calls. I want to note that CIT is not a panacea. It's not the end-all be-all, but it does seem to make a difference, and officers at the ride-alongs and responses from our surveys do note this as well. In regards to direct lines of communication, I want to mention this in 2 parts. The first part, we know that from the interviews that we conducted in the fall, a lot of organizations know of each other. They have multiple coalitions. However, there is some communication breakdown in that chain, not only within the department, but also between organizations themselves. So better communication is warranted, as it will help the community. We also know from question 8, when asked about the program referral guide, only around, I think it was 49% of officers that did not use it. Officers are aware of it and are encouraged to use it, but many don't use it. And so this begs the question of whether this is a strong enough resource on its own. And if officers are not using this, what more can be done? So opening more direct lines of communication between officers and other mental health organizations within the community could be an option, as this would help officers know who to call, what services may be warranted, and who they can go to with questions on referrals. As for Elevate, I mentioned prior that the partnership had a rocky start, but now after months of being in this partnership, our survey showed that there is overall an increased knowledge of their utility. We do know from our ride-alongs that many officers are enjoying the Elevate partnership and are able to provide more specialized help to individuals that are having a mental health crisis. From the ride-alongs, we also know that perhaps a possible course of action is to have Elevate personnel have their own car. This would allow them to come to the scene more readily, and it would keep them available for mental health calls. Also, pairing newly CIT trained officers with Elevate personnel would also reinforce the training and maintain these open lines of communication between Elevate personnel and officers within the department. I would like to end by saying that with any new program, tweaks might be needed along the way, and assimilation takes time. It is clear that the officers like the partnership and are excited for this program, and we are excited for this program to develop further in the next few months.
So taking it all in, we plan on presenting our findings to the Waterloo Police Department and the Mayor of Waterloo alongside other stakeholders in our research. We hope to present the recommendations based on what we have found. As Khan stated, we will be considering the continuation of CIT training, forming direct lines of communication, and the maintenance of the Elevate partnership, as well as the resources we found in Iowa City and Cedar Rapids. The conversations in the next couple of weeks will be crucial to ensure the implementation of our recommendations. It is our goal that the findings will help the betterment of police response to individuals in crisis and those that are in need of resources. Next slide. Thank you for your time, and we will now answer any questions you may have.